Wheeze is a high-pitched, musical sound produced by airflow through narrowed intrathoracic airways. It can be monophonic or polyphonic, and it's a common symptom in children under 5, especially with viral infections. When a child presents with wheeze for the first time, the most likely cause is acute viral bronchiolitis. Diagnosis is clinical. Management focuses on maintaining oxygen saturation above 92% and ensuring adequate hydration. Salbutamol may be tried but is usually not effective in bronchiolitis. In recurrent wheezers, a detailed history is essential. Ask about timing, duration, and triggers, such as allergens or infections. Note any family history of atopy or asthma, and look for interval symptoms or activity limitation. Two main clues help diagnose asthma: previous episodes of airflow limitation and documented reversibility with bronchodilator or inhaled corticosteroids. Use the GINA framework to assess asthma probability. The Modified Asthma Predictive Index, or mAPI, is used to predict asthma in children with recurrent wheeze. It's positive if there are 4 or more wheezing episodes in a year, plus either 1 major or 2 minor criteria. It has a high negative predictive value. Always rule out asthma mimics, especially if symptoms start before 6 months of age, are unilateral, or associated with signs like clubbing, poor weight gain, or non-response to bronchodilators. Investigations may include a CBC, chest X-ray, and allergy testing. In older children, spirometry or impulse oscillometry can be useful. FeNO may indicate eosinophilic inflammation but isn't routinely required. Device choice depends on age. For children under 4, use an MDI with spacer and mask or a nebulizer. For children 4 and above, use an MDI with a spacer and mouthpiece. Proper technique is crucial. Start with SABA as a reliever. If symptoms recur or are persistent, introduce daily ICS. Escalate treatment based on symptom control, risk factors, and severity. Always assess inhaler technique and adherence. If symptoms remain uncontrolled at Step 2, double the ICS dose. For Step 4, consider specialist referral. Before stepping up, confirm adherence, technique, and environmental triggers. During acute exacerbations, prioritize oxygen and hydration. Administer SABA frequently. In severe cases, escalate to high-flow oxygen, CPAP, or non-invasive ventilation. Systemic corticosteroids may be needed. To summarize, under 5 wheeze is common and mostly viral. Distinguish asthma from its mimics. Use ICS in recurrent wheezers. Apply a stepwise management plan and refer when needed.